I've been responded to a patient, 70-year-old male, who has an acute onset of central crushing chest pain. He has a previous history of myocardial infarction 5 years ago. However, the chest pain he's feeling now is different this time. My patient presents with being pale and clammy. His eyes are open to voice, but he's unable to obey commands. Before his collapse, my patient had palpitations and also a strong carotid pulse. My patient has a GCS of 10 made up of 3, 2 and 5, and for this reason I'm going to call an R50 for possible RSI.
The now.
My patient has also got cardiac medications such as aspirin and sildenafil. No, it's fine because it's perfect.
Here we go.
I've taken a 12 lead off my patient and confirmed that he's in conscious ventricular tachycardia. This is due to being significantly compromised cardiovascularly. I have ruled out my differential diagnoses of supraventricular tachycardia with abnormal conduction, hyperkalemia, and also anything to do with tricyclic antidepressants. My patient has the following vital signs. I've taken a full set. He has a rest rate of 18 and you can hear crackles on auscultation. He has a heart rate of 170, a blood pressure of 70/40, a temperature of 37 degrees, and a BGL or blood glucose sugar level of 7.3. My patient is significantly compromised, and for this reason I am calling him a status 1.
And there we go.
My patient, because he's in conscious VT, I'd like to sedate him first before I have to cardiovert him. I've called up clinical desk for guidance on giving ketamine for sedation, and I have drawn up, after getting my off-sided check, that I've got ketamine.
And
For the ketamine, I got my off-sided drug check for it, and also drug check my sodium chloride. I've drawn up ketamine. I have 100 milligrams, and also drawn up 9 ml of sodium chloride to make 10 mils, which means I have 10 milligrams per ml of ketamine. For my patient, because he is 70 kgs, I want to give 35 milligrams of ketamine, that is 3.5 mils of drug in the syringe. After giving my patient the first dose of ketamine, I want to make sure and ensure that he's completely sedated. So by doing that, I will now check. Hello, can you hear me? I have no response to pain or voice stimuli, in which case my patient is unresponsive, meaning the sedation, the ketamine has worked. If my patient was not sedated fully and adequately, I would then give a second dose of ketamine. I have got my patient on non-rebreathe mask at 15 litres per minute, and also a bag mask on hand in case of a cardiac arrest. In order to cardiovert my patient, I will pull out my CPGs, pocket CPGs, and turn to page 127 to follow the cardioversion checklist. I will place pads either side of the apex and sternum. Ensure my defibrillator is in manual mode. Select the lead with the visible R-way as seen here. I will select synchronized mode and allow it to sync, confirming that there is a detection symbol above every QRS complex. I have given my patient the adequate sedation, and I will just check again before I cardiovert. Hello, can you hear me? My patient is still unresponsive to pain and voice stimuli. I will select the joules of 200, and then I will start the charge. Ensure everyone is clear. Okay, everyone stand clear of the patient, please. and then I will hold the shock down until the shock is delivered. Yep. After successfully cardioverting my patient, he has returned to his sinus tachycardia. Well,
Okay.
after successfully cardioverting my patient, he has now got the rhythm of sinus tachycardia. And however, if he is to go into VC again, I shall then follow the cardioversion checklist once again.